You are welcome, and you can introduce yourself.
All right, thank you, Daniel, once again for having me in this particular platform just to discuss matters healthcare, especially the state of healthcare in our beloved country, Kenya. My name is Dr. Libeya Bethwel. My primary training or background, if you may call it, is pharmacy. I trained as a pharmacist at the University of Nairobi and got registered and licensed to practice in Kenya. Primarily, I'm an expert, or if you may call it, a consultant in health product and technology. And apart from that, I'm also an entrepreneur in the healthcare space. Apart from that, I'm also a digital marketer and really passionate to see to it that the public have an access to quality and affordable medical services. So that's me. Thank you. Back to you, Daniel.
Thank you for the introduction, Dr. Maybe we can try to go back to your experience. And how is your experience running or doing business in Kenya around healthcare and also serving Kenyan who need healthcare services? How is the experience so far?
So far, I'll say there's a lot of learning that I'm doing. Of course, healthcare is a vast space. Healthcare is a really vast space, and you can invest or become an investor or entrepreneur at any given stage of service delivery. An entrepreneur, especially at the level of health products, medical devices that are meant to be used by patients, especially those who are having diabetes, who need to monitor their blood sugar levels, or those who want to monitor their blood pressure, and many other devices that are sold. One thing that has stood out for me is the affordability of these products. There is need for the products, but a big chunk of the population are not able to afford to have the products. And so that's something that has been striking for me. And majorly, one of the major reasons is that all of these devices, we import them from outside. And when you're importing something from out, then the price tends to increase. Perhaps if we were to manufacture them locally, the situation would have been different. So one thing that has stood out for me doing business in this environment is the affordability of these products. It's beyond reach for a big chunk of the population that actually needs them.
20% of the population is in rural areas. So how can we describe healthcare in Kenya currently? If we have to say this is the white and black of the Kenyan system, or how the healthcare state is, how can we put it?
If you're looking at the state of healthcare in Kenya, it will be easier or simpler to look at it through the lenses of what I call the 6 pillars of healthcare system. Of course, delivery of healthcare services is structured in what we call pillars of healthcare system. And these pillars are 6. They have 6 main pillars. So by the time you see a health service being delivered, it means it's being supported by all of these 6 pillars. Any dysfunction in any of these 6 pillars will then mean that the quality of the service being delivered will be subpar or suboptimal to what is required to be delivered. And maybe I'll run through the 6 pillars and then give the state of healthcare in Kenya in light of these pillars. The first pillar that we have of healthcare system is what we call leadership and governance. And this is basically how at the administrative levels of healthcare in Kenya, the leadership levels of health facilities at the policy level. This is leadership and governance. The second pillar is what we call healthcare financing. Of course, we understand that finances are lubricants of any service delivery system, including healthcare. So healthcare financing is the lubricant that ensures these other 5 pillars are moving without friction. If you supply less lubricant, then it means there will be a lot of friction and service may not be delivered to the quality that is desired. So there is need for adequate financing. And when you look at financing, especially in the healthcare system in Kenya, we are not doing well. We are not doing well. Currently, financing from the national budget to healthcare is at 4%. And back in the days, it should be 2001, African countries met in Abuja, Nigeria, and they signed a document, what is commonly known as the Abuja Declaration. And in that declaration, what was agreed was that these African countries were meant to allocate 15% of their annual budget towards healthcare. And that wasn't supposed to be done, let's say, in 1 year after they've agreed. It was supposed to be done incrementally, but the target was that every country needs to have gotten to that level of 15% of their annual budget allocated towards healthcare. Currently, across Africa, only 2 countries have been able to do that. That is Mauritius and Rwanda. But the rest of us are below that 15%, Kenya included. Kenya is at 4% of the annual budget. Now, that is, if you look at it, that's a thorough underfunding of the healthcare system. And that is the state of the healthcare system as far as healthcare financing is concerned. On leadership and governance, that was the first pillar. We have a gap in the healthcare space in Kenya as far as leadership and governance is concerned. Majority of those in leadership position in the healthcare sector do not have a background in medical training. So when addressing challenges, they seem to be lacking that, what you may call experience or in-house experience of how these challenges are meant to be addressed. And so for the few situations or in the few occurrences where people with medical background have stepped up in leadership position, we've seen a remarkable difference. And so that is a gap that is there, that is affecting the quality of healthcare delivery, the healthcare service that is being delivered. The third pillar is what we call the healthcare workforce, or sometimes we'll hear it going by the name Human Resource for Health, HRH, in some quarters. And there's a big problem here. Of course, we understand that the evolution came in 2010, and healthcare is one of the units that was devolved from the national government to the county government. But that has brought chaos in this particular space. I'm sure those who are coming from Kenya, you've had strikes here and there in the counties, complaints by Human Resource for Health or healthcare practitioners in counties about delayed salaries and promotions not being there, not being released to go for training to become specialists, and many other challenges that they are facing at the county level, which was not there initially when health, human resource, or healthcare professionals were under the national government. And so under the health workforce, there's a big problem. Kenya, another thing is that Kenya is understaffed as far as human resource for health is concerned, by around 30,000 healthcare professionals. If we narrow it down to doctors only, and by doctors I mean, if we narrow it down specifically to medical officers, the ratio of doctor to patient is at 1 to 16,000 at the moment. One doctor serving 16,000 patients. Now, if we look at the recommended global standards, WHO recommends one doctor to serve 1,000 patients. It means then that we are way, way much below or way, way much off the standard that has been recommended by WHO. So that is as far as healthcare workforce is concerned. And then number 4 pillar is what is called medical products and technologies. And, a big chunk of this pillar is the pharmaceutical products. Kenya at the moment has about 1,300 plus or minus 1,300 approximate distributors of pharmaceuticals, that is wholesalers. It has around 10,000 retailers of pharmaceuticals, and it has around 40 plus, 40 should be 44, 40 manufacturing plants. Now, manufacturers of pharmaceuticals in one way or the other. If we look at the consumption of pharmaceuticals in Kenya, we consume 70% of what we consume is imported from other countries, and only 30% is manufactured locally. So it means there's a big gap in the manufacturing front. We import 70% of what we consume, and we only produce 30%. That shows you that there's a big gap as far as manufacturing of pharmaceuticals is concerned. And if there are entrepreneurs or investors out there who would like to dive into the pharmaceutical space, that is a good entry point because there is a gap there. If more manufacturing plants can be set up in Kenya, then it means we'll be able to reduce what we are importing to even less than 50%. We'll have done a great job. If we look at number 5 is information and research. The research is thoroughly underfunded in Kenya. Medical research is thoroughly underfunded in Kenya. We mainly depend on research that has been done abroad to make decisions on policy or to guide policy directions in Kenya. That's an area that also has not received a thorough attention as it should, and is a good area to invest in. And then, of course, number 6 is service delivery. If all the other five pillars are not well taken care of, then it means the quality of service that the patient is receiving will be compromised. And that is what we are seeing, because I mentioned about healthcare financing. If the system is not financed adequately, it will affect service delivery. If the workforce is not supplied adequately, then it means the quality of service being delivered will be compromised. And basically, that is the image or the picture or the state of healthcare in Kenya. Back to you, Daniel.
Thank you for taking us through the pillar, Daktari. I'm trying to look at the 6 pillars, and I feel if we have to go down into each of these pillars, we have a lot of things we can maybe look at. But maybe we can try and go or take at least 3 and we explore them further, even if we are not going to give more information about them. So for me, I'll be interested mostly to talk about manufacturing. The reason being is we have several approaches to work with us when it comes to manufacturing and relationship. The only challenge is when it comes to setting a manufacturing company, one is financing, another thing is the policy side, and the process, all that which is needed for us to set up a company in Kenya and be able to say this is a manufacturing company around healthcare. So my question to you, Daktari, is what can you say about manufacturing? What challenges are there? What opportunities are there? How can we be able to maybe focus on setting up manufacturing and encouraging more people to come in the market, and also be able to set up maybe a drug manufacturing company, a device manufacturing company, and etc. How can we go? Let's say we can try to take an instant of like taking a baby from the crawling stage to maybe someone who can work on their own. So how can we go about setting up a company in Kenya, and what are some of the policies? Even if
pharmacy business is controlled business, and by that I mean there are professional guidelines that have been set in place to control the quality of product that is being produced by the manufacturers. And so the beginning phase will be, if someone wants to set up a company in Kenya, the beginning stage will be to have a professional who can guide them on the process. A big problem that people will find themselves in is when they ignore the service of professionals in guiding them to set up the manufacturing plant, or looking at the law and all that. When I look at business or any business, I look at 3 main areas. Number 1, 3 main pillars. Number 1 is the commercial aspect of business. Number 2 is the legal aspect of business. And number 3 is what I call the technical aspect of business. And when you talk about manufacturing, the 3 areas also need to be taken care of. Once you have the 3 areas clicking, then you have a business to go. And the commercial aspect, there is need. And where there is need and you have a solution to meet that need, then it means you get profit in return. So commercial aspect of doing business, that one, there is need and there's a big opportunity. Remember, I mentioned that 70% of what you consume is imported, and only 30% of what you consume will produce locally as far as pharmaceuticals is concerned. So there is big need there. And if people want to come and manufacture, then they can have a conversation with someone who is a professional, a pharmacist, I offer those services, market research, market intelligence. So as far as pharmaceuticals is concerned, they can book a session, have a time with them and guide them on what is needed, what is imported in bulk, which gaps can they step in and fill to make, so that can help them to make an informed decision. Now, the cost of producing, if you look at the cost of, because that also falls under commercial aspect, the cost of production, I'll say for pharmaceuticals is compared to other manufacturing plants, there are incentives that have been given to pharmaceuticals. Pharmaceuticals are one of those things that are not, do not attract what we call VAT. They're exempted from VAT. So that is an incentive so that it encourages more manufacturers to set up plants in Kenya. So there are no VATs, especially also on the raw materials for pharmaceuticals, because one of the things that government is trying to ensure is to see to it that the prices of pharmaceuticals are as affordable as possible, and that goes to the manufacturing point. For those that are imported, also they do not attract import duty and VAT, to just make the prices affordable to the common mwananchi. So the commercial aspect, taxes, there's some what I call incentives as far as tax is concerned, such as VAT exemption and import duty on raw materials exemption, which make production quite low, quite cheaper. So that is one thing under commercial aspect. Now let me look at the legal aspect. Setting up a manufacturing plant has certain regulations that need to be in place, that need to be observed. Has certain, criteria that need to be met before you are given a manufacturing license by the Pharmacy and Poisons Board. Again, if someone is interested in setting up a manufacturing plant, it will do them good if they get services of a consultant to take them through the legal aspect. Again, that's an area that I thrive in. I take you through the legal aspect, what you need to observe, how much timelines do you have, the fees incurred, and everything that you need to have in place. And then you'll be good to go when you have inspectors from the Pharmacy and Poisons Board to come and inspect your facility so that they can give you a go-ahead to proceed and manufacture products. And then there's a technical aspect. Now, this is where you need to figure out machines. Of course, you've mentioned that they're expensive, and I agree to that. The machines are really expensive. Setting up a manufacturing plant is not a joke. You may need hundreds of millions. You may need hundreds of millions to set it up because the machines are quite expensive unless you are specializing in one line of product, let's say creams. But if you intend to move to other formulations, let's say creams, you need tablets, you need suspensions and syrups, then it means, or capsules, it means then you will need to invest hundreds of millions to set up that plant. And that, of course, again, you need to engage the services of a consultant who are specialized in manufacturing of pharmaceutical products, and they can guide you appropriately. But by and large, it's a profitable business if you set it up right, and it's not something that, let's say, you invest and you begin getting profits after 2 years or 3 years. It's something that you invest, but you realize the gains after years, because it's something that builds up slowly, because you need to establish an entire distribution channel. Let's say a channel which you can use to distribute your products. You've manufactured syrups, you need distributors, you need marketers to go and market your products so that there's demand, to create demand for your products. So it's not something that will happen within 1 or 2 years for you to gain traction, but it's a worth investment if you're looking to go at it for the long haul.
Happening in other country, and my interest mostly is going to Ethiopia and how they are like welcoming other countries to come and set up manufacturing. So I tried to look at the South African market also. If you look at the leading manufacturers of anything healthcare, most of the African manufacturing companies are in South Africa. So do you ever try to look at what is the difference this country are making, which Kenya is not making?
Countries have different policies as far as investment is concerned. And when you look at Kenya, different regimes have different policies also. and different interests when it comes to manufacturing. One of the things that were promised during the campaign trail by the current government is that they want to create jobs through manufacturing. And we hope that pharmaceutical manufacturing is one of the areas that they'll pay keen attention to, because it's an area that has a lot of potential. And one of the things that other countries are doing, of course, what attracts investors is incentive and a ready market for their products. Those are the main two things that attract investors. If you're giving them incentives that lower their cost of production and they have a ready market for their product, then they'll definitely flock in. And I'm not quite sure what they're doing, but most likely the incentives are inclined towards that direction. A country like Ethiopia, they could be giving incentives, and that's a win for the government, because if an investor comes, it means they'll create jobs for the local market, and that's a burden lifted off the shoulders of government. So incentives are key. If you look at the cost of production currently in Kenya, I'll say there are several factors that may make it go up. The cost of electricity, for instance, that's one thing that makes cost of production to be higher. And if other countries are able to supply electricity that is cheaper, then companies or investors may prefer to go to those countries to invest. For instance, Ethiopia, they have their hydroelectric power plant and all that, and the cost of electricity is lower than what we have in Kenya. So that could be an incentive for investors to flock into that country to set up manufacturing plants. So I think those two are the main thing: ready market for their products and incentives that make the cost of production to go low. What those countries are doing that perhaps we may not necessarily, it's not that we are not doing it, but maybe we are not doing it as they are doing it. So then our incentives may not be as attractive as what they are being offered elsewhere. Back to you, Daniel.
Okay, thank you, Daktari. I think we also need to have a way we can be able to collect the data about Africa, and also maybe be able to understand what these different countries are doing to help us maybe navigate the market. So another issue maybe we can address is more of the information and service delivery. I've been working on digital healthcare for, I think, 5 years now, and I have run or I've seen a lot of challenges around the digital healthcare. One is around policy, and another thing is now the behavior of the end users. Do you think we are ready for digital healthcare? Like, not just in Kenya, also in Africa. Do you think we are ready for the digital healthcare?
Of course, technology and all that. I've been in that space also for a while, just trying to study and understand how it works. I've been at the e-commerce space, trying to understand how it works, and also, of course, set up a few businesses around that, and observing consumer behavior around e-commerce. And of course, now looking at the digital space, digital health space, because e-commerce and digital health space are not far much apart. The simply delivery of goods or services using digital platforms, and that applies to healthcare as well. So are we ready as a continent or as a country for digital health? I say not yet there. Even for e-commerce, we are not yet there. I do business online, and one of the things that I found as a blocker is trust issues. Of course, we have rogue people who have conned the people in the name of e-commerce, where you pay for a product before you see it, but now they con you, you end up not receiving the product. And so people's trust have been deflated as far as trusting e-commerce is concerned. And the same spills over to medical services that are being offered digitally. So one is a trust issue. Two, people are very slow to make adjustments and change. And that is affecting Africans and Kenyans at by large. And then another thing is on access to internet, because you understand that digital health, of course, needs, I'll say, there's a certain level of technology that you need to access digital health. For instance, you need a smartphone to download an app so that you're able to have a teleconsult with a medical practitioner or a medical service provider. You cannot do that if you're using a phone that is not a smartphone. So you needed a smartphone or that has access to internet, or you need a laptop. And a question to ask ourselves is, what is the penetration of smartphones in Kenya? Is not more than 30% or even 20%. Another thing we need to ask ourselves, what is the penetration of internet in Kenya? Not just any internet, but strong internet that can enable digital consultation to take place. And then another thing that I found as a blocker for telemedicine in Kenya, especially now when you come to the space of e-pharmacy, is the aspect of additional costs when it comes to delivery of product. Because it's convenience that is being offered, where instead of going to a physical pharmacy to pick your products, you are ordering it online, so it's delivered to you. That is convenience. How many people are able to pay for that convenience on top of the cost of the product? And yet we know that a big chunk of the population in Kenya are living below $1 a day. So, those conversations come in place, and then you realize only a very small percentage of our population can easily and comfortably and affordably embrace digital digital health, or health services being offered digitally, and be willing to pay for it. Actually, there are companies that have done that, but if you start in Kenya here, but if you look at them and the profile of the clientele they're serving, it's a clientele with a certain characteristics, and most of these clientele are dwelling in the upper middle class areas and upper end areas, where they can easily afford convenience because they have a lot of disposable cash. So those are the conversations that we can have around digital health, and if you are ready. So are we ready? Not yet. We are not yet there, but maybe we give it time. In the next, let's say 10, 15, 20 years, then we can assess, and perhaps at that time, we'll be ready for it.
About 10,000. And I think you said about something about one doctor to about 6,000, depending on the county one is. So is there a way we can be able to bring a balance using technology, where we can be able to give everyone an equal opportunity to access maybe a specialist? And another thing is, if you look at something like mental health, a specialist is about 6,000 if I have to go and maybe get the service. And another thing around also mental health care is, it is not a single thing. It's something which need a progressive approach, or seeing a doctor. And that becomes so much expensive. If anytime I go to see a doctor, I have to pay that 6,000. So do you think digital healthcare, or what can we do maybe to try and bring that balance around the doctor-patient cases?
Balance between doctors and patients, I think we have to look at it in two ways. Number one, is not even necessarily about digitizing it, because if you digitize it and the number of healthcare professionals remain the same, then it means you will have digitized, but you haven't increased the number of healthcare professionals who are supposed to see the patients. So the first thing that we need to do is to train more healthcare workers. That is number one thing. If you train more healthcare workers, then it means that we'll have a bigger pool that will be available to serve this population. Number two thing that we need to do is what I call to deploy healthcare workers. By deploying, I mean the government absorbs them and deploy them where they are needed. We'll find that a bigger concentration of even these doctors that you're talking about is in cities. If you go to Mashinani, you rarely find these doctors. It's because in cities there is a demand, and also they are looking at where their bread is well buttered. And so they'll come to cities and work in private hospitals where the bread is better buttered. So if government is able to train, number one, adequate doctors and absorb them to government facilities or to government, then they'll have the ability to deploy them evenly across the country, so that they can serve population. Whichever place someone is, they can serve the population in those areas. Now, after deploying them is when now we can, and retaining them is when now we can have conversations of how their services can be digitized, because already the human resource will be there to serve people. So someone can opt whether to come to the hospital or to consult while at home. But that they can only do if at all there is a healthcare professional to attend to them. So the conversation should be centered around training more healthcare workers. I think that's where the rubber meets the road. Once we sort out that question, then it will be easier to do every other thing.
Do you feel like doctors are paid well to prevent them migrating to other countries looking for greener pastures? And is there something we can be able to do, even if we train more doctors? What is going to happen now to try and balance? Let's say someone is working in urban area, like in a city, another doctor is in a rural area. So how can we try to give these people an equal opportunity, and they feel what they are offering to the community is worth for them to continue pursuing the dream of like maybe helping and building and saving life?
All right, I think that's a good question and a follow-up question. Once you've trained a doctor and you deploy them in the rural areas, for you to retain them, I think one of the things that is making them to move away from those hospitals is lack of equipment to put their knowledge and skills into practice. You know, you can be a doctor in a sub-county hospital, but you're only using 5% of your knowledge to do your day-to-day activities. That is redundancy. And so most of them who are progressive, they quickly think and move out of those places, because if you stick there for 3 years, then it means you'll have forgotten most of what you are taught and trained in school. So they look for spaces where they're able to practice what they're taught in school and learn as well. And, you know, they get that in cities where equipments are available and where they're given opportunities to offer those services. So if government can equip these facilities, that is number one, with the necessary tools that these doctors can use to deploy their knowledge and skill, then they'll stick there. Two, if government can take good care of them in those facilities, then they'll stick there, because if your needs are taken care of, you are remunerated adequately to meet your needs, people won't have reason to leave those hospitals to look for greener pastures. So you look at the equipments and also you look at the services.
On the government, maybe we can try to look at what happened when the government gave the county the power to take over the healthcare sector. So I was trying to study what governor from Muranga is doing and the way he is trying to empower the community. But I still feel like there is some chance or some gap in this county. So do you think that is going to be a long-term solution to the counties? Or how can we be able, like, maybe to go about it? Do we need to return the healthcare to the government? Or how can we be able, like, to bring a balance? Because currently we have about 47 counties. And out of this county, they have different ways they are running things around healthcare. That means each county, the patients are receiving different kind of services. So how can we also be able, like, to, even if we are going to continue with the county maybe taking care or controlling the healthcare, what can we be able to do to try to bring, there is something which is missing, currently missing, as we can observe from the system?
All right, as you've rightly put, the services have been devolved, but, you know, policy and regulation is still with the national government, and policy and regulation regarding matters healthcare is still by the national government. So both the national government and the county government serve the same Kenyan. And so one thing that maybe can be done is to agree to ring fence finances meant for healthcare, because there's a budget for that. And, you know, it's unfortunate that once the budget has been approved and finances have been allocated, some of those monies are misdirected to other things. And that's what creates chaos in those counties. So if you, number one, if you can be able to ring fence money meant for healthcare, then that would be a good step that towards redeeming healthcare in counties. Whether it needs to be returned to the national government or remain in counties, there are different views to that, and there are pros and cons. And you see, returning it to national government is not something that the president can wake up and pen it down the next day. No, because it's something embedded in the constitution. Actually, it's not the national government that decided that healthcare should be devolved. It's Kenyans who decided through the referendum that happened in 2010. And so for it to go back to the national government, it means then they have to go to the referendum and return it to national government. And, you know, that takes a whole process again. And so there are pros and cons. And if well managed at the county level, healthcare can do well. The problem is not even devolved. The problem is management at the county level. Management at the county level. There are counties that are really grateful that healthcare was devolved. Counties, especially that they were not doing well before 2010, they are really grateful that healthcare was devolved, because now they can have surgeons, now they can have specialists, because counties are managing healthcare. Initially, all the surgeons and specialists were either in Nairobi or Eldoret or big cities. They were not in those counties. So healthcare can work in county governments if well managed, and if some certain ring fencing is done, especially on financial issues. If that cannot be done, then it will be safer to return it to the national government. That will be my take on it.
How can you describe the current hospital status in each county or different counties, and maybe the level-wise?
Healthcare status in different counties, this will be my take on it. We have very beautiful buildings, but in terms of human resource, I mean, we don't have human resource to serve people in those buildings. You will see counties are in a competition to build the most beautiful hospitals, but when you step inside those hospitals, the equipments are not there and the human resource is not there. Buildings do not offer healthcare services. Healthcare services are offered in buildings by human resource using equipments. So, it's high time that county bosses stop setting up buildings, beautiful buildings, in the name of hospitals, yet they are not equipping those facilities or employing staff to run those equipment to serve people. We'll end up with a lot of beautiful buildings in the name of hospitals, and yet services are not being offered. Number two, we've had cases of counties upgrading facilities to level 4, level 5 to sound fancy. That's okay to elevate facilities, but elevating a facility is not just a change of name. There has to be a commensurate accompaniment of services being delivered. The services that are delivered at level 4 are higher than what is delivered at level 3. Services delivered at level 5 are higher than what are delivered at level 4, and same applies to level 6, which is higher than what is delivered at level 5. So if a county is upgrading a facility, there is need for them to also upgrade the services that are being offered there. We've had situations where counties are upgrading facilities by name and on paper, but when it comes to service delivery, you'll find a level 5 delivering services that are supposed to be delivered by a level 3. That is a disservice to the people of those counties. So that would be my take on that as far as facilities are concerned in the counties. And we've also seen different county bosses parading photos of products being delivered to their facilities. It will shock you that most of what they're parading is just syringes and waters, normal saline, and what we call normal saline and dextrose solution. If you look at the actual drugs, people are still buying drugs out of those facilities because the pharmacies are not properly stocked. So people are gaining political capital by circulating photos of syringes being delivered, and they call it pharmaceuticals and drugs, and yet in actual sense, in those hospitals, they are not drugs. So we need an honest conversation at the county level, and people should put their priorities right. It's better you build one hospital and stock it and let it offer services adequately to your people, instead of building 10 to take photos and share online that you are building hospital. That would be my take on that.
And maybe try to look at opportunity currently we can see they are available around healthcare in Kenya. So what are some of the opportunities do you see available in Kenya where not just the international investors or anyone who is interested in Kenya healthcare or Africa, but also Kenyan can also be able to invest in?
Currently, opportunities lie everywhere. If you look keenly at the 6 pillars of healthcare service, of healthcare system. So opportunities are plenty. If you go by the 6 pillars of healthcare, you can't miss an opportunity. Just take for someone to sit down and assess what is on ground, perhaps employ the services of experts, and then they can guide them through. But the opportunities are plenty, beginning with leadership. There's healthcare financing, healthcare workforce. And when we talk about healthcare financing, it touches on insurance. We need innovative insurance schemes that will be able to help people and still be able to benefit the investors. Health workforce, plenty of opportunities right there. There's medical products and technology manufacturing and the entire distribution system. There are gaps to be filled and opportunities are plenty. Information and research, that's another area. We have very few contract research organizations or even organizations that are private entities that are interested in research. I know research has a lot of money as far as data is concerned. There are less or few entities engaged in that. And then, of course, service delivery. If someone decides to set up a hospital, there's a big population that needs the services. But the bottom line is, as far as investment is concerned, it has to be run with business principles. Otherwise, If you step in and you haven't assessed your idea well, then you are likely to burn your fingers. So there are plenty of opportunities if someone looks or keenly at the healthcare pillars. Yeah, that would be my take on that.
Close with the recommendation. What can you recommend anyone thinking around healthcare in Kenya, the status of it? Any recommendation around healthcare in Kenya?
Recommendation in which angle?
Mostly for us who are like depending on the healthcare system daily, the policymakers mostly, because we feel like also we need to engage policymakers around healthcare. So do you have any recommendation you would like to maybe pass out or share to anyone who can take an action?
All right. My recommendation will be that we need to tilt the inclination of our healthcare system towards preventive medicine. Initially, the healthcare system that we have currently was built primarily to handle what we call communicable diseases. And communicable diseases included things like malaria, things like HIV. That was back then because that was the burden that we are battling with. But over the years, because of lifestyle change and all that, we've been having an increase in what we call non-communicable diseases. And this include diabetes, hypertension, we have cancers, we have what we call asthma, we have what we call coronary, what we call COPDs, coronary obstructive pulmonary diseases or disorders. And this obesity, these are conditions that are coming as a result of lifestyle change. Our system hasn't been built to handle that. And so we need a re-engineering of the entire system so that is able now to address challenges that are coming as a result of non-communicable diseases, as a result of lifestyle change. That is where we need to put our focus, and preventive medicine is key in this. And we talk about preventive medicine, you're talking about lifestyle change. You're talking about appropriate taking your diet into consideration. You're talking about exercise. You're talking about frequent medical checkups to detect any disease build up before you actually become ill or sick. So that would be my take and recommendation. Let us